Hello, and welcome to the Radcliffe Institute for Advanced Study. My name is Immaculata DeVivo. I'm one of the co-directors for science programming. Welcome to today's program, The Future of COVID-19 Epidemiology. Before we get into the program, I'd like to acknowledge all the members of the Radcliffe Institute Leadership Society and all our annual donors who are watching this afternoon. Your generosity keeps Radcliffe programming free and open to the public, and we thank you. So today's event, this program, The Future of COVID-19 Epidemiology, is the first in a series of events that will lead up to the main science symposium in the spring, The Future of the Future. This will take an in-depth look at the modern systems of prediction. Now, traditionally, this is a one-day event that we hold on campus, on the Radcliffe campus, but because of the remote platform, we're going to spread the symposium over 3 events in the spring. We will look at the future of Earth and climate, the future of wealth, and the future of artificial intelligence in health. And today's program, when we were discussing it and planning it in the spring and into the early summer, we thought, gee, will there be lingering interest in COVID-19 by the late fall? And judging by the number of registrants today, over 1,500, I'd have to say there's more than just a lingering interest in COVID-19 epidemiology. Who could have predicted that? So I'd like to introduce the speakers and their titles in the order of appearance. And it gives us great honor with a big capital H to introduce these expert epidemiologists. They're on the front lines, tireless, sleepless nights, logging in many hours to guide us through this pandemic. These are friends and colleagues. So today's program will be moderated by my friend and colleague, Professor Mark Lipsitch. He is a professor of epidemiology in the Department of Epidemiology and Immunology and Infectious Disease at the Harvard T.H. Chan School of Public Health. He will moderate our 2 wonderful discussants. Again, my colleague, Caroline Buckey, who is an associate professor in the Department of Epidemiology at the Harvard T.H. Chan School of Public Health. And then, of course, we have Dr. Mujay Sevic from Scotland. Thank you for spending your evening with us. She is a clinical lecturer in infectious diseases and medical virology in the Division of Infectious and Global Health and the School of Medicine at the University of St. Andrews in Scotland. So before I indulge me a few more seconds so I can unfold the program for you today. So today's program will open with some framing remarks by Mark, followed by brief presentations by our speakers. After the presentations, Mark will engage the speakers in discussion and then turn to moderate the audience Q&A. We encourage those watching to use the Q&A feature on Zoom and to submit your questions at any time during the programs. Since we anticipate a lot of questions, we ask that you keep them short so we can answer as many as possible. And with that, it is my pleasure to pass the virtual floor to my friend and colleague, Mark Lipsitch.
Thank you, and thanks to all of you for attending, and welcome. As you're well aware, COVID is the story of our lives right now. In many ways, there are 62 million confirmed cases globally and 1.5 million deaths approximately that we know about, probably many more. There are 15 million or so cases in the United States that we have known about cumulatively, and we're racing towards 300,000 deaths, racing far too fast, in my opinion. It's the biggest public health event of our lifetimes, and because not only has the virus taken a toll on people's health and lives, but the impact of the virus has changed our society in almost every aspect: how we live together, how we eat together, and how we specifically don't eat together sometimes, how we do and don't go to school, how we get healthcare or miss healthcare. It's vastly exacerbated many inequalities in our society. It's had many different kinds of impacts on us. And now we're speaking together on a day when the first individuals were vaccinated with a vaccine against this infection that was unknown to the world a year ago. The first individuals outside of a clinical trial received a vaccine in the UK this morning, their time. So an extraordinary story of both missed opportunities, bad responses, and also extraordinary scientific foresight that led us to the point where we had the vaccines ready to go in a time frame that was almost unimaginable. From the scientific standpoint and the standpoint of our discipline of epidemiology, there has been a remarkable change as people have had to work together at unprecedented speed across time zones, virtually. And I can say happily that I got to know Professor Chevik through first Twitter and then Zoom. We've never met, but we've co-authored 2 papers together. That's happened a lot in this epidemic. And the role of social media in connecting people, in spreading good information and misinformation is unprecedented. The role of preprints in spreading good information and sometimes misinformation before peer-reviewed papers come out. The role of press releases in spreading the results of clinical trials before anyone has seen a scientific paper. And the remarkable fact that we've had to build our instruments to measure this epidemic while measuring it, and really had to create a system from nothing. And then the last thing I'll say is some of the ironies of this epidemic, and there are more than I have time to mention, but 2 have struck me particularly in the last few days. One is the irony that the United States, which was listed as the top most prepared for a pandemic country in the world, has had one of the worst responses of any country in the world. While countries that are usually the recipients of advice and aid, like Rwanda and Senegal, have been celebrated appropriately for their remarkable responses, as have several other countries that people were predicting much worse outcomes in. The second irony that has struck me really in the last few days of discussing the epidemiology and the questions of vaccine prioritization is that people say, almost as if it's obvious, that essential workers are those who we underpay and who are most deprived in our society. And calling someone essential and then describing them as underpaid the irony has been particularly striking as we try to figure out who should get vaccines. So there's much more to say, and I look forward to hearing much of it said by these distinguished colleagues, and I'm happy to turn the floor over to Caroline Buckey.
Thank you, Mark. It's a pleasure to be here today. I'm going to share my screen and show some slides. Today, I'm going to, just briefly before we get into the discussion, I'm going to talk about specifically some of the methodologies behind the forecast that you might have seen about COVID-19 and describe some of the methods, some of the reasons that the modeling can do a good job of predicting the future to the extent that that we can, and the constraints on these models and when they can't be used so well. So I want to compare and contrast different types of models. There are many different kinds of epidemiological models that we use to try to understand what might happen with this epidemic. The first category, and the kind of model that I'll talk about the most, I think, can be imagined in the same way that this Heath Robinson gadget is designed here. So it's a very simple, transparent, mechanistic model where you can see exactly how it works. We write down equations that attempt to recapitulate the mechanism of transmission. And then we can ask questions. If we assume X, then what might happen. And these kinds of models can be very helpful. They're usually conceptual. They often are qualitative in the sense that they're not trying to make a prediction about a particular number, but they're trying to understand the types of dynamics that might occur. And a nice example of this was published by Mark very early on, where the idea was to try to explore how different assumptions about immunity and the kinds of lockdowns that we might impose would impact the longer term dynamics of the epidemic. So this was before we knew a lot about some of the details of transmission, but it was a sort of a thought experiment, a way of thinking clearly about the possible futures. And then we have what you might traditionally think of as a forecast, an attempt to predict the future. These are models that try to say quantitatively what might happen, how many cases, how many people will be hospitalized in the coming month, and so on. And these can be broken down into two types. The first is like this picture of SimCity, as a kind of a simulation where we take everything, many details that we know about a particular population, and we run, similar to the other kind of model, a mechanistic model where we're trying to recapitulate infection dynamics, but within a more realistic and specific setting, to ask how many cases might come up in the next, X time window. And then the other kind of model is a statistical model, purely looking at what's happened in the past, what might happen in the future as a result. So this maybe doesn't have as much of a mechanistic framework. And these kinds of forecasting models have come under a lot of fire over the last year, because of course policymakers need to know something specific, which is how many cases will there be over the next 6 months or whatever. So this is an example from an ensemble forecast where modelers, in this case from a team in UMass Amherst, they take many different forecasts and they try to come up with a consensus about what will happen. And you'll notice here that it's only projecting out for about a month. And that's because beyond a month, we really don't have a good handle on how this epidemic is going to go. And I want to try and explain to you why that is. So of the mechanistic models, they all come down to an underlying structure that can be described as an SIR, or a susceptible infectious recovered model. These are very simple models, and they're sort of the workhorse that epidemiologists use. Everyone in the population exists either as susceptible, infectious, or recovered with respect to a particular pathogen, and the dynamics follow a relatively simple formula of how they happen. So in this case, we have a nice epidemic curve here. And the general findings of these kinds of models are that epidemics die out. Either the virus goes away or susceptible people run out. And that's mainly how epidemics die out. The pathogen, like a forest fire, runs out of trees, runs out of people to infect. One of the early mistakes with some of the forecast models was that people looked at the Wuhan curve. They saw that it went away, like this model does in this picture, and they assumed that that was because it was a similar mechanism, but it wasn't. It was because we changed behavior. So the mistake that was made was thinking that we could transpose that Wuhan curve elsewhere and it was going to hold. And that was a miscalculation about the mechanism underlying transmission. So I want to talk about the basic reproduction number, which is a factor that leads from these simple models. In the simplest ones, the recipe for calculating the basic reproduction number, which is a measure of the growth rate of the epidemic, is these three parameters. The first is the probability of infection given contact. So if somebody does breathe on you, what's your probability of becoming infected? And you multiply that by how long people remain infectious for. Now, both of these are things that we can measure. We could do experiments. We can think about ways that we can try and parameterize them for our models. The third one is much harder. We have to multiply that by the average number of contacts per unit time per person in the population. Now, if you think about the kind of contacts you have and imagine on average, how many people do you contact per day or week, that's quite challenging. It's context specific, it depends on the place, and it can change over time. So the basic reproduction number is also context specific and can change over time. So of course, in the absence of the vaccine and treatments, we have been relying on interventions which impact these different aspects of transmission. First, we wear masks so that we try to reduce the probability of infection if we are close to somebody. Of course, we trace and isolate people to try to limit the duration that people are infectious and making contact with other people. And social distancing and lockdowns, the whole point of those has been to try to reduce the number of contacts per unit time that are happening in the population. And that's the premise of the flattening the curve interventions. So the next thing you need in your model to try to make a prediction about what will happen next is to know the state of the system. So where are we on that epidemic curve? How many people are susceptible, infectious, or recovered? Now, the problem with that is that we have a lot of uncertainty in the underlying data. What we have to work with are usually confirmed cases. Okay, so that is actually a subset of total cases, and I'll talk about this more in a second, but that's usually what you're fitting your model to. Because that's unreliable, some models use deaths because they're easier to count, they're more reliable, and then they try to back calculate case counts from that. But what we really want to know is about transmission events, which happened prior to the confirmed cases. And so all of these models are constrained because we don't know how many people are infected in a population at any point in time. And so when we think about different populations, when we're dealing with data to fit our model and make a sensible prediction, we have testing capacity issues. So we only know the subset of people that got tested, and that's only a subset of people in the population that are infected. And increasingly, we can look for antibodies. So look for antibody positive people with serological surveys, and that can tell us how many are immune. But this remains a major source of uncertainty in our ability to predict what will happen. And then what actually happens is going to depend on the place, the population, the interventions in place. And so here I'm just comparing 3 countries with very different demographic structures. These population pyramids show the age of people in that country. Up the side, we have the age, and we have the fraction of people in the country, kind of that's how wide, and we have it broken down by gender. And we know that people who are more likely to get sick and die are older people, and that happens at a very different prevalence across different countries. Similarly, children who are relatively low risk make up very different proportions of the population. So the context really matters. The other thing that really matters and that we try and put into the models, but again, it's very challenging, is to understand how households are structured. So that, when we're doing these lockdowns and social distancing, we're moving transmission into the household. Trying to understand what impact that will have will really depend on the context. And then the final thing, the contact rate parameter, is also highly dependent on the population. This picture shows the results of a survey where people are asked how many contacts they have per day with people of different age groups. And you can see the heat map here. So the red dots are lots of contacts and the white and gray are less. And even between Italy and Germany, you see very different contact patterns. And that's going to have a big impact on what the epidemic will do. Similarly, how people interact, where they go to work, all of these things are highly dependent on the location and what's going on socially. And so this makes it challenging to make sensible predictions. What we've seen with this epidemic is there are also heterogeneities on a very local level beyond national differences that have really changed who is affected and how the epidemic has gone. So this map shows the prevalence of antibodies in pregnant women from around New York City. And you can see that in some parts of New York, this was actually quite early on, some parts of New York, it was up to 1/3 of pregnant women had already been infected, whereas in Manhattan, there was very, very little infection had happened there. So again, predicting what's going to happen on large scales and small scales overall is challenging because these are local epidemics. The other thing that we've seen, and I think Mark mentioned it earlier, is an incredible amount of inequality in terms of socioeconomic status, race, ethnicity. So this shows you excess mortality in different age groups in Cook County in Illinois, split up by age. And the pink line shows Black, and the turquoise line shows white people. And you can see that the racial disparity in who dies is incredibly striking. So again, in terms of our predictions, we can make predictions based on the epidemiology, and then there will be all of these context and demographic specific differences that will determine what actually happens. So just to finish that thought, we talk about forecasting as if it's like a weather forecast, and we're used to trying to understand it that way. But it's really different, because with a weather forecast, if everybody brings their umbrella because the forecast says it's going to rain, it will still rain. But if we forecast an epidemic and then we do social distancing, we change the contact rate, we change the parameters of the model, we change the reproduction number, and we may not have an epidemic, but it depends on what we do. So it's very different, and it becomes a social and political issue in addition to being an epidemiological one. And I'll just finish by saying that one of the challenges with making a sensible forecast and trying to understand what might happen in a quantitative way is undermined by the fact that we have had a huge amount of difference in the uptake of interventions due to different receptivity to what's happening and different political aspects. So this just shows the public trust in government measured over time since 1958. We are at an incredible low with respect to public trust. On the right, you see a heat map that shows Twitter data showing anti-mask sentiment across the US. These are the things that make a difference in the epidemic trajectory, and they're very hard to put into models. And so the epidemiology now is really dependent on some of these social political issues. So I will thank you, and I will hand this over now to Muge.
Many thanks, Caroline, and thanks a lot for inviting me to this excellent event. So I'll just share my slides. So actually my presentation will complement what Caroline already mentioned. So I'll give some overview about my overall experience over COVID pandemic, because I've been providing some scientific advice to the governments and how that works, and the evidence generated by scientists, how that feeds into the policy making and the difficulties basically informing policy. So some of my disclosures, I guess, like, as everyone, sorry, as Mark also mentioned, since the emergence of COVID-19, there's been an unparalleled scientific effort to characterize the virus, understanding transmission and clinical course of COVID. And we've heard a lot about following the science. And what actually following the science means. So evidence and science is only a tool, but not necessarily a prescription for policy. Policy combines science with values and priorities, and it's also influenced by public opinion. On one hand, there is a need to inform the policy, and on the other hand, there's also need to engage effectively in public dialogue, which I find quite interesting, and maybe we haven't done as much as needed, because public opinion on scientific issues can have a significant influence on policy at government level. I think the major challenge has been the speed of data being generated during COVID-19, which hasn't been seen actually in any other pandemics. Is at the moment we have over 90,000 publications on COVID-19, and which is extraordinary, but also quite overwhelming. And the other challenge is that the diversity of scientific voices are being missed, because, as you can see, the percentage of men in COVID response decision-making bodies was almost 100% at the beginning of the pandemic. This kind of shows that pandemic has reinforced the prevailing gender norms in which men continue to be allocated to leadership roles. This basically overall kind of changes the way the policy is being influenced. So I would like to look at the transmission, because transmission still has an influence where we are now and how we're going to go forward, and also in terms of like vaccination priority list as well. And when we look at transmission, I think COVID made us wake up to the fact that we don't fully understand how other respiratory viruses transmit, let alone COVID-19. And we're dealing with a virus that thrives on human contact, but still the relative importance of different transmission routes, we don't know. For example, this study was from the US. This is a case control investigation study that basically looked at close contact, those with close contact with persons with known COVID-19, and showed that adults positive, who had positive test results were approximately twice likely to have reported dining at a restaurant, where those with negative SARS-CoV test results. So in a way, this kind of shows us some understanding about where people might have been, but it doesn't really tell us definite information about where, when, and how transmission occurred. So when we look at the transmission dynamics, we know that it's very complex and multidimensional. And what we know so far is that transmission depends on several factors, including contact pattern, environment, host factors, and socioeconomic factors. So we can't really, simplify some of the complexity here. And this is one of the challenges of scientists, to actually explain the complexity and maybe try to inform the policy in a much kind of informed way. So when actually thinking about, for example, a restaurant example, when you think about case A, who has a much smaller network, who's able to work from home and has sufficient space at home to self-isolate. So if this person is exposed to the virus, it may actually end up being a terminal infection, meaning that they won't pass it on to others. Whereas for case B, who has a large network, maybe who works in a public-facing job and lives in a crowded housing, they will be much more likely to pass it on to others. So it's, we need to kind of put all these results and findings of contact tracing studies into a context. And kind of moving on from the same example of restaurants. So in a way, if a setting is not visited very often, it doesn't matter how high the relative risk is. So that's why one of the key things we need to get across in presenting transmission risk is the relationship between relative risk, exposure frequency, and population attributable risk. So for someone visiting the same setting once a week will not have the same exposure risk as someone being there every day. So in a way, like we've seen this a lot in terms of socioeconomic inequalities and transmission dynamics, as Caroline already mentioned, we are seeing there's a strong suggestion that socioeconomic inequalities are associated with risk of infection. And we know that socioeconomically disadvantaged groups have not been able to reduce mobility as sharply as other groups. It's mainly because of socioeconomic status, job security, and they're exposed more because of long working hours. And they're also at risk of onward transmission because of household crowding, living in multi-generational households, or inability self-isolate because there's not enough space. So, and also adverse living, working conditions, and underlying pre-existing health conditions increase the susceptibility to infection and increase the vulnerability for adverse outcomes. So overall, I think we need to kind of change our way looking at transmission dynamics. It's the disproportionate exposure risk and the differential onward transmission risk that speak to the need to spend more to prevent infection in a personal support worker compared to a restaurant customer. Acquisition would be the same, but it would end up being a different overall influence on the pandemic and spread of the infection. So we need to think about overall for transmission, systemic factors that influence viral propagation and not simply the characteristics of individuals or places they go. So my challenge has been over the last couple of months is kind of explaining the complexity of this transmission dynamics to people in the policymaking level. And explaining that it actually requires data from multiple approaches. We need to recognize that, a place that might have caused an outbreak may not always the location where actually transmission happens. So it's there's a challenge, but we also need to move from change from anecdotal and judgmental opinion-based policy to evidence-based policy formulations. And this can be done through creating and synthesizing the evidence in a way in real time. And we have the tools to systematically do that. And we also need political commitment for evidence-driven policy. So these are my acknowledgements, and I'm passing on the floor to Mark. Thank you.
Thank you both for terrific starting points. I wonder if both of you could address a question that I had, and that's also coming up in the Q&A from some of the listeners, which is about about the mechanics of interacting uncertain and tentative evidence with policymakers, and how, to give it some texture, I guess I would be very interested in asking Caroline specifically how you deal with the fact that sometimes predictions and forecasts tend to suggest that people have no agency. And you mentioned that that's the difference between weather forecasting and epidemic forecasting. So how do you communicate that? And then Muga, I'm quite interested to know how you deal with the uncertainty as in many of things we've talked about in the past, but almost everywhere, the measurements are changing, the measurement systems are changing, there are imperfections, the data are not what we would love them to be. How do you communicate evidence when the evidence itself is somewhat uncertain? So maybe start with Caroline.
Yeah, it's a good question, because I think there is this misconception that we should be able to create like a weather forecast. You should be able to make a quantitative prediction about what will happen, and in a lot of cases you can't do it. One of the ways that we've been monitoring the behavioral side of this is using data streams from mobile phones, for example, where you can start to measure behavior, movement patterns, and those kinds of things. And integrating those into some of the reports to policymakers can be helpful, because it illustrates to them how people have reacted to things like 4th of July weekend or travel for Thanksgiving. They can start to see that the behavioral dynamics are linked to what's happening with cases further down the road. And I think policymakers have come a long way since February in understanding the intimate relationship between human behavior and the epidemic itself. Now, that still doesn't negate their need to have an idea about what might happen. And I think there, the onus is on the modelers and the scientific community to be very, very clear about uncertainty and to be transparent about how the models work and where the main uncertainties lie. And I think that discussion is something that is complex, and obviously people are trying to make decisions quickly, but it's absolutely critical. And if you look at the graph I showed of the forecast from the ensemble model, it had very wide confidence intervals, very wide uncertainty moving into the future. And I think that is really the key. It's making sure that policymakers understand the source of uncertainty and the relationship between these behavioral issues and the epidemic itself, and B, that they see the limits of the forecast, because the forecasts only go out a certain amount of time and they have confidence intervals attached. So for me, I think that's been something that we've been working on over the year, and a lot of policymakers are now really up to speed on how to think about the models.
Thanks, Muga.
It's a very, very good question. And I think many scientists who are advising the governments are having the similar kind of concern. I think, as Caroline said, our kind of knowledge has limits, and I think it's important to relay that message to the policymakers, and also trying to identify the gaps in our knowledge. That's something that I found quite useful, saying this is what we know so far, and these are the gaps, and this is what's needed for this to happen. And because, you know, there's contact tracing data coming from test and trace system, and there are a lot of scientists, extremely amazing scientists who could do a lot of analysis to answer some of that question in real time. So this is what we've been trying to do, especially in Scotland. And the other thing is, I think making the decisions also require values and principles and vision of the type of the society we want to be. And that's been one of the leading decisions for schools, for example, in Scotland, because we started with the principle that education is a human right, and that was our starting point. And that kind of changed the way we looked at school and school opening discussion. So I think it's science is limited to what it can tell us. We can explain also quantify the increased risk of opening schools or closing schools, but we also need to put some principles and vision into the decision making.
Wonderful, thanks. There are enormous numbers of really good questions, and we're only going to, even if I group them, we're going to end up dealing with only a fraction of them. But one sort of theme, I think, so one pair of questions that came in that I think is a really interesting one is, what are we doing when we try to control the epidemic? What is our goal? And the person asked, are we protecting hospitals, or are we protecting people, or are we doing something else? And has that changed over time? Either or both of you.
Well, I think, Mark, it would also be interesting to hear what you have to say about that as well. But I think that has changed over time to some extent. At the beginning, the whole flatten the curve premise was that we wanted to give ourselves some time and prevent hospitals from getting overwhelmed. And I think that is something that we continue to have as one of the very few interventions that we can use to prevent health system collapse. And so I think that was one of the goals. And then, of course, things have shifted over time. And it depends on the context, of course, but in the US, after that initial surge, when we moved into the summer and the cases came down, I think that there were quite local decisions made about what the goal was. And that has been shifting. And of course, it's a very political, kind of decision. What is the goal here? And again, this goes back to the previous question, which is, how do we work with policymakers? One of the ways you can use models is to try to test out different types of interventions and see what might happen. And so as the policy shifts and targets shift for what we're trying to achieve, I think that one thing that's really important, and as Muge pointed out, is this iterative relationship between scientists, the changing evidence, and what policymakers are trying to do, because ultimately the science community exists to create evidence and try to support policymakers, but our job is not to decide what the policy should be per se.
You want to add anything, Muga? Got lots of other questions if you want to move to a different one.
Yeah, I think it was a good answer.
Okay. Yeah, I think there are a lot of questions about duration of immunity and the vaccine, and how we incorporate the vaccine into models, and who should get the vaccine first. There are really a million questions So maybe Muga, if you could address what we know about immunity from the vaccines and what we don't know. I'll take a crack at that, and Caroline, if you want to add.
Yeah, I think what we know so far about the vaccines available and passed through the phase 3 stage is that a majority of them basically prevent severe disease. And that's really important because we want to take the pressure off the healthcare system. And majority of countries also, I think, prioritize older age groups because we know that almost every 5 years, the risk of mortality increases, almost doubles over the age of 65. So as far as we know, the immunity provided by the vaccine would be at least, as good as the natural immunity and potentially much more robust. And T-cell immunity, it's been shown to be lasting more than 6 months, but it really depends on the severity of the infection. So, but the other aspect is that whether these vaccines would be able to prevent transmission. And we also need to understand whether it will prevent asymptomatic infection, for example. But there is some, I think, hope in that preventing severe infection may also, decrease the transmission in a way, because we know that there's some correlation between severity of illness and the onward transmission. So that's a good thing. But still, I think we need to have studies ongoing while we're administering this vaccine in real time to have much, much better understanding.
Great. Yeah, maybe I'll take some of the questions about who gets it and how we think about that, and how we incorporate models, vaccines into models. I'll put in the chat a preprint that just came up on medRxiv this morning from a group that I'm a part of. It's actually a collection of alumni of our center, most of whom have moved on to their own jobs and have trainees of their own. So it's been a fun sort of reunion activity, trying to figure out how to allocate vaccines and how to use models to assist in that. And so if people want to look at the paper and see an example of a preprint that is being shared in real time, that's one. But to get to the substance of the question, I think the issue that Muga brought up about whether and to what extent vaccines protect against infection is a really crucial piece of the puzzle. The sort of competing ideas about how to use a vaccine are either to use it to protect individuals who you vaccinate, so the so-called direct protection approach, or the indirect protection approach of vaccinating the high transmitters, and then trying to protect everybody else by slowing transmission and building up herd immunity. One of the challenges of the latter approach is that we don't have good evidence yet about the degree to which that can work, because we don't know how much it blocks the vaccines, the individual vaccines block transmission. So there's, I think, a fair amount of support for the notion, and certainly I support the notion that we would prioritize those who get severe disease when they get infected for receipt of the vaccine. That requires identifying them, and several of the questions were about how hard it is to identify those people. But as Muga said, age and comorbidities are really very, very strong determinants. And while they don't predict every single person who gets a severe illness, they are very, very predictive. So the sort of direct protection of those at high risk of complications, and especially those at high risk of complications and of infection, like long-term care residents, is pretty much at the top of every list by every expert committee that has decided about it. And there's more discussion about whether the next tier should be Sorry, and also healthcare workers are at the top of everybody's list. There's more discussion about the next tier and whether that should be those at highest risk of complications or those at those who are essential workers and highly exposed. My particular preference comes down to the high risk of complications for the reasons I said. But I think it's a civic discussion. As Muga said, this is not a question of science only. This is a question informed by science, but also by values and by competing interests. I mean, whether to put teachers ahead of people over 65 is a serious question, and there are good arguments on both sides, and they achieve different things. And in the process, in the case of scarcity, it is a real choice that does not have a right answer. It has better and worse answers, perhaps. Caroline, do you want to add anything on that topic?
I was just going to say that this, the quality and duration of immunity, both vaccine derived and from infection, and whether it blocks infection or it just prevents severe disease, is also going to be really the critical feature of how well we can do with forecasting and prediction in the longer term. So, what the trajectory of the epidemic will be in the context of vaccines, maybe more than one vaccine, against the backdrop of people who already have had the infection at very different rates in different places, it's going to become, I think, harder and harder to predict what will happen. And so from that perspective, some of these unknowns about the vaccine are going to be really crucial. And then the only other thing I would say is that there's going to be very big differences between countries as well in how much vaccine they get, how much they can afford, and who gets it. And so these discussions, as you said, they're ethical nationally, but they're also, this is a global conversation about how we think about preventing transmission of this virus. And it's important to remember that we've only managed to eradicate 2 pathogens ever. So, if this is going to be with us for a long time, we need to think about the vaccination effort as a global effort.
Thanks. There's shifting gears a bit, there's a question, if you could wave a magic wand and change one behavior, what would it be? Might be different in different countries.
I mean, I think globally, when we look at all the data, one factor, which is socioeconomic factors, is a huge influence, not only in terms of risk of exposure, but also risk of developing severe disease. So I guess we need to work harder to address some of the socioeconomic inequalities in our societies. And this also comes back to the vaccine debate. I think, we can learn from some of the uptake for other vaccines, especially, for example, in the UK for flu vaccine that's also given to over the age of 65. With the universal age-based program, we know that uptake is not uniform. So people who are poorer or in, ethnic minority groups are much less likely to be immunized. And even among older patients, greater socioeconomic deprivation is associated with decreased uptake. So I think, this COVID pandemic, exacerbated some of the, socioeconomic inequalities in our societies, and we need to kind of do much more and address these.
I agree with Muga.
A more technical question, Caroline, someone asks, please elaborate on why the 1 month horizon to forecast. Is this COVID specific or generally for all epidemics?
The 1 month, I mean, it's arbitrary in a sense. The 1 month is how far into the future we think that it makes sense to make a quantitative prediction about the number of cases that will happen. So to some extent, it is COVID specific, because people's behaviors are changing so quickly. And of course, the things like the serial interval, the dynamics of the disease itself, that makes sense. And so really it just reflects how well we think we can forecast into the future. And although 1 month is arbitrary, it's, you know, somewhere in that range is probably makes sense given the importance of all of these social dynamics that are very hard to measure and predict. For other kinds of infectious diseases, it's going to be slightly different, but the underlying concept still holds, which is, you know, all infectious diseases have some social component, and the more important the social, political, behavioral component is, to some extent, the harder it is to forecast out any length of time. So conceptually, that just becomes difficult because human nature, especially when things are highly politicized, is quite hard to predict.
Yeah, and I might just add, I think that intersects with the serial interval term Caroline used, but which is just the interval between cases. So that's on the order of a week for COVID-19. It's on the order of several years for HIV infection. And so while behaviors can change just as fast, well, actually, the risk behaviors for HIV tend to change more slowly, and the time horizon on which today is sort of similar to the future is much longer for something that moves more slowly like HIV or tuberculosis than for something that can really double in a week or two. Let's see, there are lots of good questions here. Someone has asked about the politicization, and again, I think the two countries' perspective will be interesting. Have you ever seen a similar level before, and are there some lessons to be learned and applied to the present?
I don't think I've seen this extent of politicization around interventions that are on their face so uncontroversial. So the level of political feeling about wearing a mask, which is not particularly, you know, it doesn't have adverse effects, and it seems like it should be straightforward for people. You know, the extent to which that has become political has been very surprising to me. And there have been other highly politicized epidemics. I think HIV had a lot of political dynamics involved. But for this kind of outbreak, you know, I think this is unusual. But of course, this is relatively unprecedented. We haven't seen a global pandemic like this on this scale. So, to some extent, perhaps it's not surprising that we've seen in today's digital age with so much information swirling around everywhere that we've seen so much politicization. But others can comment. I don't know.
Yeah, I mean, I think in addition to the, you know, politicization at the kind of political level, we've also seen some polarization among scientists as well, and that's been quite public. And that's initially I've been quite concerned because in a way, in academia and in science, we kind of you know, debate and come to middle ground or learn from each other, and that's how science progresses. Because if we all agreed with each other, we can't really make any progress in science. And but I feel that some of that discussions have been quite toxic. Maybe it's because it has been you know, quite public because we've been using social media. Everyone is able to express their opinion. So I guess like that's one of the lessons that we need to learn, and hopefully can reflect on this, because as Caroline said, I mean, some of the discussion points is quite, you know, we can think about empiric measures, we could talk about trade-offs and different kind of viewpoints. But that discussion and politicization, you know, in front of public, I felt sometimes quite uncomfortable as a scientist.
On a different topic, Muga, you made reference to the need, and I did too, to understand impact of vaccines on infection and transmission. Are there ways using households of vaccinated people in trials or in other ways to study the impact of vaccination on transmission?
Yeah, absolutely. I mean, there will be some studies ongoing, for example, in the UK, where we will be following some of the vaccinated patients. In a way, like we need some sort of case control studies to understand the transmission, and households are an amazing way to, in a way, understand the transmission dynamics. The other places would be nursing homes, and also like we will be looking at other long-term care facilities, understanding the transmission dynamics and how that could influence. And I think we will also have the results of the study in a year time, because for example, in Oxford study, all the participants have been doing twice weekly swabs, and we will have much more understanding about asymptomatic shedding. And there will be much more studies about immunology as well in this age group and different age groups.
Okay. I think last question. We've unfortunately had so much to talk about in the US and UK and similar countries. We haven't adequately addressed the global scale. So I would ask if either of you would like to address how did China manage to control things so dramatically, or the question of why the patterns of the epidemic seem to be so completely different in large parts of Africa.
I can answer. I think in if we look at the trajectory in China and in other Asian countries that have done well, South Korea as an example, they acted swiftly and decisively, and they have quite a centralized approach that has really been intensive and has affected people quite a lot, but people have been compliant with interventions and it's kind of worked for them. In contrast to somewhere like the US, which we have a very large decentralized, or not very much federal leadership, and then, very diverse population. So to some extent, I think that has made a difference. I think sub-Saharan Africa is fascinating. I think there's still a lot of unknowns just about some of the transmission dynamics that might be different. And I think there are some countries, you mentioned some of them before, Rwanda, Senegal, Botswana, that have done a really fantastic job, and their experiences with other infectious diseases have allowed them to pivot successfully to do a good job of controlling this pandemic. I think it remains to be seen. I think that there are still unknowns about why the severity and extent of the pandemic have been so different beyond the demographic differences I showed earlier, where there's just in some places in Africa, there's just far fewer older people and many more young children, for example. But I think there's still mysteries there. And it will be interesting when we see the results of seroprevalence surveys to see whether there was a lot of asymptomatic carriage and we didn't see it, or whether indeed there has just not been so much transmission. And I think that's still an open question.
All right, we are very nearly at time, so I will stop it there. Thank our phenomenal speakers and commentators, and turn it back over to Immaculata for our closing statement.
Thank you. That was fantastic. I learned so much and a lot of talk about the vaccine, given that the first person was vaccinated today. Given time, this concludes our program for today. I want to thank you all, the panelists, for your thoughtful presentations and perspectives, to Mark for moderating for us, and the audience for terrific questions. I want to also say that today's program has been recorded and will be posted on the Radcliffe website in about a week, so give it a little time. And for upcoming events, virtual events, videos, as well as our symposium, our big science symposium in the spring. For the dates, please visit www.radcliffe.harvard.edu. I want to thank you all again for joining today. And I want to thank our famous expert epidemiologists. They made epidemiology cool. We knew it was cool. Now the whole world knows epidemiologists are cool. Thank you and have a good night.